Bismillah ar-Rahman ar-Rahim. We're starting session 5. I'm, with us is Dr. Isa Al-Salmi. He's the senior consultant, head of renal services in Oman Royal Hospital. And myself, Dr. Ahmed Amr. I'm a senior consultant cardiologist, Prince Sultan Cardiac Center. Dr. Isa will introduce the first speaker.
Thanks a lot, Ahmed. It's our pleasure today to start our meeting with Professor John Fung. John has an impressive and very elaborate CV, so I will not mention all of it, but he's a professor of surgery. He has he graduated with honors. He has multiple committees and as well academic position, as well as editorial post and editorialship. And I would like really John to start his presentation.
Well, thank you. So when I was asked to give this talk, I thought there was a lot of topics to cover. So I asked Dr. Shaheen what he would like for me to focus on. And because sort of the theme through this whole GCC Congress has been on organ availability and organ utilization, I thought I would speak this morning about the status of liver transplantation with the focus on organ utilization. Most of the data that I will present to you this morning will be coming from an article that was published last year that I helped write. And this is an annual report that comes out from the database that constitutes the United Network of Organ Sharing, the U.S. Annual report. And so it's relatively up to date. And then I'll add additional information which I think is pertinent to addressing some of the issues in liver transplantation. So first of all, I think it's good to hear that the results of liver transplantation in the United States, and in fact throughout the world, is gradually improving. And this is results of 1-year patient and graft survival for both deceased donor as well as living donor grafts. And you can see in the green triangle line that about 10 years ago, the results for living donor survival using the living donor liver allograft survival was substantially less than for deceased donors. But over the past 10 years, what we've seen is a gradual improvement in this outcome. And we'll talk about this a little later. Part of this is related to the increasing experience in living donors. But you can also see in the deceased graft survival in dark blue has gradually increased, and correspondingly the patient survival has also increased. So this has gone hand in hand with an increasing gap in the demand for liver transplantation. For every transplant that's done, there are 5 patients on the waiting list who needs a liver transplant. And overall, the mortality on the waiting list has really not changed much over the past 10 years. So what I'm going to talk about this morning, it will focus on both deceased donor as well as living donors. First of all, in the deceased donor arena, we have utilized the UNOS database to understand what risks are part of the donor characteristics that impart additional risk for graft failure. And we know for many years now that donor age is an important factor. And as you see, the decades after the age of 40 imparts an increasing relative risk of graft failure, such that a donor over the age of 70 has a 65% increased risk of graft failure compared to a donor less than 40. And if you look at some of the other characteristics, including cause of death, stroke, for instance, has a 16% increase. Donation after cardiac death or non-heart beating donors, which we heard Dr. Luke Noel talk about, is also imparts about a 51% increase in graft failure. And then technically reduced size and split liver grafts also impart a risk of 52% increase. So to talk a little bit about DCD, we heard about the ethical issues about DCDs. What I'd like to talk about are the clinical issues. Clearly, in DCDs, or non-heart beating donors, the overall impact on patient graft survival is substantially lower in terms of the survival. In this retrospective analysis of the UNOS database, almost 10% worse outcomes at 1 year and 3 years related to graft survival, and a smaller but substantially significant decrease in patient survival. This is related to higher retransplant need due to primary non-function, as well as late due to biliary complications, which I'll explain more. And clearly, the impact of the donor age in DCDs also increases graft failure. This is the risk of relisting for primary non-function in the DCD compared to the brain-dead donors that you can see. There is about a 50% higher risk of graft failure due to primary non-function in the first week following transplant. In addition, late risk of DCDs is the development of intrahepatic biliary strictures, shown in the evolution in this slide of an early postoperative T-tube at 2 weeks post-transplant, followed by a 1.5 month afterwards, the development of biliary strictures shown on the right. And this is a substantial risk factor reported in the U.S. to be anywhere between 30 to 50% of patients who receive a DCD graft will develop this complication. So the impact on long-term survival is shown in this slide, with the dark line being substantially and significantly lower than the use of brain-dead donor livers. DCDs, over the past 10 years, you can see that this is a logarithmic scale, and this shows that the brain-dead donors in the set of bars on the left has shown a gradual increase in the number of donors, but a relatively flat retransplant rate in the second set of bars at about 7%. In the DCDs, there has been an increasing use of DCDs, increasing number. You can see that in the third set of bars, and still a relatively high incidence of retransplantation at about 12% higher. 12%, which is higher than the 7% for the brain-dead donors. There has been an increased focus on the use of DCDs in the United States. You can see here that the number of grafts have actually increased over the past 10 years, except more recently, after 2008, there has been an actual drop in the use of DCDs for livers simply because of the increased risk imparted by the use. So what is the pathophysiology of this biliary complication? So there has been an analytic or anatomic analysis of what we postulate the pathogenesis to be. And what you see here is a liver, and the bile duct obtains blood from the hepatic artery via a complex set of vascular network around the bile duct. In the DCD then, when blood stagnates during the warm ischemia associated with death, we believe that the microvasculature of the bile duct develops thrombosis, and this leads later to biliary strictures due to ischemia. So with that hypothesis in mind, we also linked this to several findings that we had obtained from clinical observations about over 10 years ago, which is the use of fibrinolytic agents, in particular urokinase, streptokinase, and more recently the use of TPA, or tissue plasminogen activator, which helps to lyse established blood clots. The safety of TPA given in a clinical situation has been defined with its use in ischemic stroke. And we link that with an observation that in patients with early hepatic artery thrombosis after liver transplantation, we could rescue almost 90% of the grafts without the development of biliary strictures with early thrombolytic therapy and revascularization. And this has been validated in animal models. So since my arrival to the Cleveland Clinic in 2005, we started a program of DCDs. And what I would like to show you is the results of a deliberate use of thrombolytic therapy in liver grafts from DCDs. We are constrained in Cleveland without the ability to use heparin in the DCD donors, which potentially exacerbates the microthrombolytic, the microthrombi in these DCDs. So we have a process where we give after the procurement of the liver, flushing the liver with heparin, and then using TPA at 0.5 milligrams per 100 grams of tissue of liver mass into the donor hepatic artery in the back table. And then after revascularization, we simply allow the TPA to sit in the liver for about 15 minutes as the liver warms up to lyse the clot, and then we revascularize the artery. And by doing this, what we found, these are the demographics, and I won't have to go into too much detail here, except you can see that about half, at the very bottom, half of our livers go into patients with cancer. The overall results show that we have about a 6%, in contrast to the 30 to 50% that I mentioned before, historically in the U.S., with one diffuse biliary stricture shown on the left and one focal stricture shown on the right, and a number of anastomotic strictures which are probably technical in nature. And overall, patient graft survival are quite good, 88% one-year patient survival and 82% one-year graft survival, realizing that causes of death in high-risk patients with HCC are shown in this group. So retransplantation, one for the biliary stricture that I showed you in the previous slide, and one primary non-function. So we believe actually now with validation from other centers that using DCDs with thrombolytic therapy that this may be one answer to improve the outcomes of DCD livers. Now, I showed you the factors associated with poor outcomes in a previous slide. There has been a mathematical equation used to actually define a donor risk index, and this utilizes age, cause of death, race, and cold ischemia time. The higher the DRI, the higher the risk of graft failure. So you can see in this slide over the past 10 years that the use of higher risk donors, as shown in the the black, as well as the donor risk index of 1.5 to 1.8, has gradually increased, and this is not surprising. If we look at, interestingly, the overall retransplant rate associated with the donor risk index, we can see that, in fact, retransplantation rate shown in the first set of bars on the left have actually decreased over time. I won't explain why I think that's the case, but clearly the retransplant rates have fallen from 10% down to 7%. This has not been seen in the low-risk DRIs, as you would expect. These are optimal organs from the range of donor risk index from 0 to 1.3 and even up to 1.5. What we do see, though, is a decreased retransplantation rate in the higher-risk DRIs between 1.5 and greater than 1.8. You can see in the set of bars on the far side, right side, that the donor risk index greater than 1.8. In fact, the retransplant rate has dramatically fallen from 16% to 10%. Retransplant causes haven't really changed too much over time. Primary non-function followed by technical hepatic artery thrombosis are the leading causes, followed now by recurrent disease, persistent biliary complication rate, and chronic rejection, and the rest of the causes being relatively infrequent. The other good thing that we've seen with retransplantation rates with retransplantation is the survival after the first retransplant has actually increased from 65% now to almost 80%, with a smaller increase in primary liver transplant outcomes, as I had shown you in an earlier slide. Also, what we've seen is the timing for retransplantation has gradually changed. If we look at analysis of the taking all of retransplantation and breaking them into 4 groups by quartile, what we found in the second set of bars from the left is the survival rates have gradually increased, as I showed you in the previous slide. The timing for retransplantation has changed. So in the first period of 5 years of this analysis, in the third set of bars, you can see that most of the retransplants were done in the early phase. That's the first set of bars, first gray line in the third set of bars. And then over time, as time from retransplantation increases, the retransplant numbers have fallen. And survival rates, you can see in the middle set of bars, really haven't changed. In the second set of bars from the right, you can see in the second 5 years of this analysis, retransplantation is focusing mostly on late. And you can see that the slope of the curve is such that the retransplantations are more frequent in patients longer after transplantation. And in fact, survival rates on the far right have also increased over time. So deceased donor outcomes I've shown you with 10-year survival rates now in the 60% for patient survival or better. Living donors, interestingly, have had in the U.S. analysis even better outcomes than for deceased donor. And this is somewhat surprising because when we look at the actual number of transplants with using living donors, the numbers have fallen and have been substantially suppressed over the past 10 years. This is related to following a peak of living donor liver transplantation in 2002, a drop-off and a relatively low level of living donor liver transplants in the United States. There have been a number of speculations why, but clearly high-profile donor deaths. It's highlighted last year in the U.S. with 2 living donor deaths, one in Boston and one in Colorado, certainly puts a chill on the development of living donors. And the risk of death, well, if we look at the U.S. as well as worldwide experience of donor deaths, this is an older report from 2006. You can see already 14 patients have died from donation, 2 donors requiring retransplantation. Overall risk of dying after living donor liver donation itself is about 0.4%. This does not include more recent deaths, or I mentioned the 2 U.S. deaths last year, and an increasing number of deaths in developing countries. We know, for instance, this year in Delhi, there have been 2 additional donor deaths in India, and this is clearly also seen in other countries, including Japan and China. Nevertheless, in Asia, the dependency on living donation is shown in this slide, with the vast majority of transplants being done in Asia being living donors. This is true in Korea. You can see they're doing now 800 living donors a year. At the Asan Medical Center, they're doing over 300 living donors a year. And even in this region of the world, in Turkey now, doing a large number of living donors. So what kind of living donors are we talking about? Well, the liver is comprised of 2 lobes, right lobe and left lobe. The left lobe is smaller than the right lobe. The estimated percentage is about 60 to 65% of the liver volume is right lobe and 35 to 40% left lobe. And technically, the left lobe graft is easier to procure than the right lobe graft. And in fact, if we look at donor complications, from Hong Kong group, just highlighting the very bottom, you can see that the left lateral segment or the left lobe graft in the first 2 columns, group LL and group L, have an overall complication rate of about 7 to 9%, whereas the right lobe graft, shown in the third column, has a complication rate of 28%. And this is also consistent with the ratio of donor deaths, about 0.1 to 0.2% for left lobe grafts and 0.5% for right lobe grafts. So left lobe grafts are preferentially should be utilized because of donor safety issues, but because of the liver size is in some cases too small. And when the graft weight body weight ratio falls below 0.8%, as this study showed from the Kyoto group many years ago, the two curves, XS and S, being extra small and small, being grafts that are less than 1%, you can see that the serum bilirubin is substantially higher than in grafts that are greater than 1% graft weight body weight ratio, shown in the three sets of curves on the bottom of the left side. And this is associated also with diminished patient survival, shown in the right curve, with extra small grafts having the worst outcomes. Why does this occur? Well, when the liver is too small, the liver remnant in transplantation is hyperperfused, and this leads to a syndrome called small for size graft. And this is characterized by elevated bilirubin, encephalopathy, development of ascites, and coagulopathy. So as we now understand the relationships, clinical factors that are associated with living donor liver transplantation, the three factors are graft weight body weight ratio, as I showed you before, liver mass, the inflow, the pressure volume of portal blood in a cirrhotic patient, as well as the ability of the liver to drain that blood, the outflow capacity. So the three factors associated with the function of a small for a small graft is related really to liver mass, inflow, and outflow. So what we can do is modulate. There are some things that we can modulate. Outflow capacity is to optimize the venous outflow of the liver. This can be done by careful reconstruction of the veins draining the liver. Here, most often in a right lobe graft, requires reconstruction of the venous drainage for segment 8 as well as segment 5. A number of techniques have been utilized, most of these incorporating some type of jump graft into the vena cava. This allows for optimal drainage of segment 5 and 8, which can be a large volume of the right lobe graft and lead to better function. There are also very innovative techniques using patch grafts, venoplasty techniques to drain other segments of the liver. The Asians have been particularly innovative in how to optimize the venous outflow. We can also modulate the inflow, such as to reduce the pressure of the portal venous blood coming into the liver. How can this be done? Well, a number of techniques, including portal cable shunt, splenic artery ligation, splenectomy, all reduce the portal blood flow to the graft and have been utilized by different centers. The problem is that we don't have a scientific method to measure how much blood to divert, but we do think now that we understand the optimal portal venous pressure to maximize the regeneration of the graft. And this is using a portal cable or portal systemic pressure gradient of about 15 millimeters of mercury or less. And this data from Japan also shows the difference in survival when the portal pressure in the living donor graft is less than 15 millimeters compared to when the portal pressure is greater than 15 millimeters. Lastly, the ability to modulate the liver mass. We talked about right lobe, left lobe, but there are some innovative techniques to increase the liver mass. This is a technique that the Koreans have first utilized. It's called a dual graft. It utilizes a left lobe or segments of right lobe from two donors. So there are two grafts from two separate donors that are implanted in a very unique technical modification that then allows sufficient liver mass to obviate the small for size graft. You can see here the first transplant that was done in 2000 with the dual graft shown in the upper right, and then regeneration 2 months later. The graft looks almost like a full-size graft. This utilizes a technique which I think has some merit to do in even not just dual-size graft, but just left-lobe grafts. And this requires what we call a left-to-right inversion. And you can see in figure A, panel A, is the technique that's used for most left-lobe transplants, which is an orthotopic position draining through the left and middle hepatic veins. The right to left inversion actually takes that graft and puts it into the right hepatic fossa and basically flips the liver over. You can see in the picture now the left lobe graft lying in the right upper quadrant with basically the posterior position of the left lobe graft now being in an anterior position, and vice versa. You can see that the left lobe hilum being reconstructed. In addition, the use of microvascular techniques have also improved the complication rate, such that biliary complications, hepatic artery thromboses in the living donor graft have been minimized. So, in summary, liver transplantation continues to be a very effective method for treating patients with acute and/or chronic liver disease. And worldwide, in the United States, we depend heavily on deceased donor grafts, but worldwide, the reliance on living donor grafts is certainly, as Luke Noel showed, a disparity between the East and the West. Overall survival rates, however, using either graft, living donor or deceased, are quite good. With the living donor graft, we do know now that we can improve the outcomes by modulating the liver mass, the outflow, and then the inflow, and using microvascular techniques to minimize complications. It does remain organ shortage the primary reason that we can't provide the service to more people. There are both methodologies to increase both deceased donor and living donor in order to address the shortage. I do think that as we move forward, there are new technologies which I didn't talk about, how to preserve or better have these both cadaver organs as well as living donor organs work better. But I think this is a challenge for us going forward. Thank you.
Thank you very much, John, for a very impressive and elaborate update on the liver transplantation. Now the questions from the floor. Yes, Francis.
John, that was an excellent presentation and very comprehensive. So it's not so much a question as enabling to hear more. Could you elaborate about the thrombolytics in DCD some more, and some more about the ex vivo preservation of a DCD liver? You and I travel all over the place, and we've seen in the Groningen and Peter Friend in Oxford, right, and the guys in New York, etc. Perhaps to hear those comments, because it's a fascinating talk you've given, and there's lots I know that's still inside there.
Yeah. So the thrombolytic therapy protocol has now been utilized by a number of other centers. I can tell you, for instance, University of Toronto, where 20% of their grafts were DCDs, they had a 50% graft failure rate, both to acute primary non-function as well as biliary complications. Marcus Selzner has effectively now done 25 DCDs in the last years without any biliary complications, no graft loss, using the protocol that we outlined. There are a number of programs that have utilized this. I think it's an option. The other option which you alluded to, which I think is also quite exciting, is the use of machine preservation. Cold storage itself is not very effective at preserving organs or regenerating organs. And so what Professor Delmonico was suggesting is these machine preservation. Now, there are two types of machine preservations for livers that are being developed. One is cold preservation, and this is the efforts of Jim Guerrera at Columbia, and who have presented some data which looks promising. But what I think being more physiological is normothermic, body temperature per machine perfusion. The technology is still in its infancy. Peter Friend in the UK has started a lot of this. But again, Marcus Selzner, as well as our own center, have taken the concept of using body temperature perfusion, either with whole blood or fractionated blood, or an asanguineous solution. And this is a technology that was first proposed by Lauren Brazil, who worked with Jim Sorelli many years ago. And the idea is to use oxygenated either perfluorocarbon, asanguineous, or blood with growth hormones or TPA circulating through organs to allow the organ to start to engage in repair processes at body temperature. Animal models clearly show that normothermic perfusion is better than cold preservation. There have not yet been any human studies with this, but an NIH grant actually that Michigan and Cleveland, as well as Lauren Brazil, is moving forward. We have a IRB protocol to start doing this. So I think hopefully, in the next GCC we can present some of these machine preservation data, but I think it's quite promising.
Any more? If there's no more questions, we'll move to the second speaker, I guess, in case of the time.
We'll move to the heart now.
Yeah, we'll ask Dr. Jihad